in Michigan for the last 11 years, and it involves the doctor or hospital or whoever committed the mistake can apologize to the patient and not have that held against them unless they've done something willfully wrong. The patient then has to wait 6 months or 180 days before they can go to court. They start mediation with the hospital or the doctor or whoever, and they can bring a lawyer because they may still want to go to court at the end of the game, but they work out what's going to be done by whoever committed the mistake to make good for it if they didn't kill the person, or what are they going to do?
You almost have to stop the medical malpractice train.
Well, because what it does, and the interesting thing is, and this I think is also historic, the Massachusetts Bar Association, the Massachusetts Trial Attorneys Association, which do most of the malpractice claims, and the Massachusetts Medical Society have agreed on this structure that we put together. And that's been a problem for a long
Dick,
time.
I've seen it over and over where the physicians will say, I'd like to be more efficient, but I have to practice defensive medicine.
Right.
So I know what the answer is, but I'm going to order 9 tests.
Well, there are different figures as to what defensive medicine costs, but at least the minimum I've seen is it adds about 15% to the overall cost of healthcare. Now that's, with that 15% is billions of dollars.
Well, I was going to say, it's not a small number.
No. And it's wasteful and doesn't help the patient at all, or very little. But if the doctor gets sued at some point, it's evidence that they did everything they could.
Some lawyer will say, you could have run these 3 tests.
Right.
Why didn't you?
Yeah.
Well, because I know they wouldn't help. How do you know unless you run the test?
Right.
And all of a sudden, a jury may agree.
Sure. And so the system that's worked in Michigan and that we're modeling, we think will improve the communication between the doctor and the patient and the hospital and the patient. Will not have people going away feeling, I got hurt and nobody cared. Will allow more communication on what happened so we can learn from it. And if it's something that is because of the way the procedure is that others are having the same problem, you can fix it and improve the quality of care. Another thing that we're doing in the bill, and this will take a little longer to see the direct results, although we know it works, is that there's a company in Newton, but their clients are some of the big corporations that self-insure their health care for their workers. They found that about 15% of medical diagnoses are wrong. With cancer, some forms of cancer, up to 44% of the diagnosis is wrong. Now what that means is when you get the wrong diagnosis, you get wrong treatment that isn't helping you. It may even be harmful.
Well, you're delaying
and you're
the
delaying,
right treatment.
You're
You
right
get
treatment.
worse and worse when they figure it out.
So it's a system where you kind of almost automatically have a second opinion if you can get, without an additional cost, you get a second opinion and it's by a panel of experts, not by, I'm just going to go to another doctor. The particular problem that you seem to have, the conditions, gets looked at by a panel of physicians that really has seen it all, basically. And it seems to work. So we set up a task force to really look at that. How can we get that service that many private companies give to their employees? How can everybody, on your Medicaid, no matter what your insurance is, how can you get that kind of service to minimize then improper treatment and care, which costs a lot of money too. So as we do things like that, we also we're going to have an assessment on the insurance companies for 2 things. We already assessed them for a lot of things anyway, but we're going to assess them for about $40 million a year for 5 years. $20 million of it will go into a trust fund for electronic records. Now, we've been very successful getting money from the federal government for that. We got about $35 million we're dealing with right now to begin the statewide network. They tell us that they think the federal government is going to be good for about another $50 million over the next 2 years. But it only is for hospitals and large doctor practices. We need to roll out the electronic technology in the record to skilled nursing facilities, to health centers, community hospitals, the ones that aren't getting it now, physician practices, even small physician practices. So the state and the money in this trust fund would be used for grants to help pay the cost of that and get that implemented so everybody's got access to it. We also take 20 million of that 40 over the next for 5 years and invest it in public health. What can we do for health and wellness programs that will help address things like asthma and diabetes, and we'll let communities and nonprofits
at the root cause versus being reactionary.
And really get people thinking positively and creatively about treatment that works, and things, and diet and exercise, whatever it might be, that helps, that we can then encourage other communities to replicate. So if we can think a combination of things like that to focus on reducing the cost of care and the wasted care that goes on, and that, we hope, will allow the companies to drop their costs. And what we do is we've had some success now in this part of it. We did this in 2010, was that we created a mechanism that whatever insurance you have, whatever the company is, that 90% of that premium, whatever you pay, has to go to healthcare costs, not administration, not advertising, not any of that sort of thing, not the insurance side of the ledger. The national, and average, the federal health reform wants all the states to get to 80%. So we're already at 90%. Now, most of the companies have actually achieved that in the records, what they're reporting to the insurance division. A few of them are still struggling to get there. And by the end of June, those that aren't there this year will have to rebate the difference to their policyholders. So some folks are going to get a check in the mail for some portion of their insurance premium because the company didn't make the 90%. And we keep that in place. In this bill that we're doing now, we roll that for a longer period of time so that we continue to push the insurance companies not to keep building up their money, but to spend it on health care or give it back. It's not supposed to be
So it seems like, once again, Massachusetts is ahead of the curve.
I think we're very much ahead of the curve. There's a number of those features are all new. Now, the global payments thing that we're talking about, there's different ways of producing it. They call it accountable care organization or medical home or bundle payments or whatever that we push toward. There are some other states that are doing that to some degree. That we're going to do it for all of our public programs and encourage the private insurers to do the same thing, some of them already doing it. And we think that will produce a more coordinated care that will keep people healthy or manage their care.
I'm going to lead with a few questions and then end up asking you, Massachusetts healthcare, vilified across all the square states, is it politics or reality? But let's look at it. Before, and you were one of the leaders, started down the road, we had less than 98% insured people. So it seems like the efforts have gotten us all the way to 98%.
Right. And with kids, it's almost 100%. It's even better.
It's even better then. So as far as participation, you can't argue that the Massachusetts model hasn't worked.
No, it's. I mean, people would still like to pay less, and that's of course what's behind our
But that's a given.
current initiative. Yeah.
That's a given.
And in fact, a couple of my colleagues argue that we should have a single payer system, more like Canada tends to have, some of the European countries have. And we did a study 10 years ago, and we spent about $100,000 with consultants. And they said at the time, if we were to move to a single payer, the government basically paying it, you wouldn't have insurance unless you wanted something beyond what the standard policy is that everyone had. We would have to raise taxes then by $4 billion in order to have enough money to do. Some people wouldn't have to pay insurance or as much for insurance, but it wouldn't always be the same people that are paying more in taxes.
Dick, I've heard the panacea of socialized medicine. It would be the best thing ever to happen. You get all the medical care you want for free, whenever you want it, as you want it. I mean, I've heard all the arguments.
It isn't really free, though.
Yeah, and then I remember I lived in Paris for 4 years. Now, at that point, we had socialized medicine. And everybody I knew had to take out supplemental policies, or, I mean, if you need emergency care, you got it.
Yeah.
But anything that wasn't emergency care, you got put at the end of the list.
Well, and I had the study updated. I had a very bright young lady who was an intern. Governor Dukakis had sent her over to me, and she just got her degree, law degree from Harvard, and a public health master's from Harvard, a dual degree. So was pretty smart.
Yeah, not the dimmest bulb on the tree.
And so she looked at the report that was done, and she might have actually liked the idea of a single payer, but she looked at the report that was done and said, well, what if we did this now? What would be the numbers of inflation? Well, we'd need $6 billion in increased taxes. And when everybody wants to cut taxes, so
Right.
that would be a hard sell. We also would, a lot of things have happened just in the 10 years. We've done major health reform. The federal government now has done major health reform, and hopefully it sticks. The healthcare costs have changed upward in that 10 years. So it's a lot different situation, but it would be more costly. And plus, you still would have to ask the federal government for permission to do it in a variety of waivers for some Medicaid and Medicare to make it all work. So it just.
But again, from a practical point of view, I saw the French government limit what they would pay physicians.
Yep.
So all of a sudden, the only people, I mean, you had two groups of people. One, people who really had a passion to practice medicine. And there are a number of physicians. But a lot of the very bright people didn't want to go into med school for, coming out middle-aged before they've received their specialist degree to make a nominal salary. So now they had to start having immigrant physicians come in because they would be the only ones that work for the national health care wage. I mean, part of me says I kind of like the fact that, in general, as you say, it's not the dimmest bulbs on the tree that make it through top colleges to get into good med schools and practice. So, again, I listen to all the utopian rhetoric, and I just have a hard time because I lived it for 4 years.
It would be a hard transition, and that's the other piece of it. There would be a lot of people out of work because you wouldn't need all the people selling insurance and working in the insurance industry. You'd need some of them move into government jobs in order to administer the program. But it would be a shift away from private sector to public sector, and that's usually not the way to go.
And saying, boy, is that how we increase efficiency?
Yeah.
What am I missing there?
So it's we don't think it'll work, even though some people would like to do it.
When I look at costs, I mean, what used to be absolutely repulsive to me is the term medical inflation, because it just seemed like we were trying to rationalize.
And that's what we're trying to do, because what your insurance rates basically are the product of medical inflation, higher costs.
Yeah, we all got tempered with, inflation is 2%, 3%, but medical inflation
at least
is
double.
10.
Yeah.
Double or triple.
And that's what we want to address to get those in line. And we think the mechanism we've set up will get us there. And we've got enough different, the one thing that we've done in the debate going on right now is something, we should be more aggressive. We should go below inflation. Well, you might be able to get away with that a little bit.
How far can you swing it?
Well, and it's also given, the economy still is not really robust. It's still pretty tenuous.
Yeah, we're limping along. Don't rock it
and
too
you don't know
hard.
what's going to happen in Europe with how that's going to impact us. And New England, more than the rest of the country, a lot of our economic stuff is with
exports to Europe.
Yeah, and so given the state of the economy and the uncertainties of Europe and the uncertainty certainly of Washington between the election and the inaction in the Congress, we thought we want to move in the right direction, but don't go overdo it, because then to correct for that will be expensive.
But even now, let's look at costs.
Yep.
So years ago, when it came in at 9%, 10, it was almost a sigh of relief on the FinCom.
Yeah.
I mean, when you really think about it, that's 2-3 times inflation minimum. But this year, for the first time, we actually are going to spend less than we thought we would.
Yeah.
I mean, part of it's going on the state plan. I can come up with 100 reasons if I want to shoot holes in it.
Yeah.
But at the end of the day, more money in our taxpayers' pocket seems like a good thing to me.
Well, and we've seen the last year and this year,